Hello and welcome to the Essential Substance Abuse Skills webinar series. I'm Kate Trans, and today we have Bob Barrett speaking on treatment knowledge. This training series is brought to you by the American Indian and Native Addiction Technology Transfer Center, or ATTC. We are one of 4 national focus centers serving the ATTC network, which also includes 10 regional centers and a network coordinating office. To learn more, please visit our website. The series is designed to be a broad overview in preparing for written alcohol and drug certification examinations, to enhance existing knowledge, and to improve overall competence and treatment outcomes. Please be aware that this series is not meant to stand alone, and previous education and training is necessary in order to pass alcohol and drug certification exams. Please check out our other upcoming webinars in this series, as well as our American Indian and Alaska Native Behavioral Health series, which takes place on the first Wednesday of each month. We always welcome suggestions or topics or speakers, so please feel free to make suggestions either in the Q&A pod or by contacting me at the email address or phone number provided on this slide. Our center is a NADAC certified educational provider, and CEHs are available upon request for a $15 fee. A request form is available for download in the Files pod in the webinar screen, and I will also be sending this form in a follow-up email to all who attended. You may notice that the Files pod also contains handouts of today's presentation, so you'll be able to view those at a later date and review what was covered today. That will also be included in the follow-up email as well. Immediately following today's webinar, you'll be redirected to our GPRA evaluation. GPRA stands for the Government Performance and Results Act, and SAMHSA asks us to evaluate our events in order to comply with this act and provide improved performance assessment and accountability. The survey asks about your satisfaction with the event and will take less than 10 minutes to complete. We thank you in advance for helping us to improve our programs. You will be muted for the duration of this webinar. So if you have questions about the presentation or about the Adobe Connect system, please use the Q&A pod by typing them in the field at the bottom. We will address questions at appropriate points during the presentation. I would also like you to be aware that this webinar records participant attention time. If you minimize the webinar or are working in another window, the system will record your participation as inactive, which may be reflected in the number of CEHs received. Today's speaker is Bob Barrett. Bob has worked in the field of addictions treatment for over 20 years. He's currently serving as the Executive Director of the Minnesota Association of Resources for Recovery and Chemical Health, and he's been a friend of the ATC and has been both an expert trainer on many of our programs, but has also been a partner on lots of projects that we've been working on recently. So I'd love to welcome Bob, and I'll pass things over to him now.
Thank you, Kate, and welcome everybody to the webinar today. We have a pretty good attendance, it looks like. So let's just look here real quick at the training objectives. I don't need to read them to you. I will give a little disclaimer right off the bat that when I talk about buprenorphine, I'm not an expert on buprenorphine. I'm not a doctor, and I'm going to provide some information about it. But if you have specific questions around buprenorphine or other kinds of medication to treat addiction, I would welcome you to send those questions to us, and we'll answer them after we consult with people who are more knowledgeable about it. Otherwise, I think I can speak to these topics pretty well. Kate will pause at a couple of points throughout the webinar so that you can ask questions, or if I need to clarify something, anything of that nature. Evidence-based and best practices. What I want to point out here is that there is a hierarchy of determining whether something's an evidence-based practice, a best practice, or a promising practice. And typically that's determined by the amount of research and data that's collected on a particular approach. Obviously, based on the slide, evidence-based practices are the more have more rigorous research behind them, more data to support that they're an effective approach. Best practices, slightly less. in all of those terms. And a promising practice may be a relatively new approach that simply hasn't had the time yet to develop the data and the research behind it to move it up the ladder to best practice or an evidence-based practice. Now, there's been a long time, how should I put it, a little bit of tension between researchers and practitioners around implementing evidence-based practices. And that tension has to do with the fact that researchers would like you to implement a particular approach as it's intended and as the research has supported it. What practitioners find often, though, is that they don't either have the resources or the personnel to implement a particular approach as it's intended. And this isn't through no fault of theirs, but oftentimes these kinds of approaches that are proven in research get sort of watered down or amended in some way so as not to fit the research exactly. And that drives researchers crazy, but practitioners have a very practical point of view where they say, hey, you know, we can't do this with our staffing levels and with our financial resources. So there's that balance sometimes that practitioners have to find with implementing an evidence-based or a best practice as best they can based on what they are able to do. I hope that makes sense. Promising practices, I think, is an area where I'll touch on that today because there are several changes occurring, or many changes occurring in behavioral health that will impact how this field, the field of addiction treatment and behavioral health in general, how it evolves going forward. And I think the next few years are going to be interesting in terms of how we see the field evolve. And it may not look, in many ways, it may not look like it does now. Personally, I think that's probably a good thing in most cases, but we'll touch on that more as we go through the presentation. As far as the characteristics of addiction, I just pulled this from this quote here from the American Society of Addiction Medicine, the 3rd edition. And I thought it captured at least most of the important characteristics of addiction. I would like to point out throughout this webinar, I'm going to talk in generalities about addiction treatment. I say that because addiction treatment, like any other healthcare issue, has many facets to it, has many complexities to it. And whether you're working with a specific culture, whether you're working with men only, women only, adolescents, all of those things play into how you approach a particular group of people or a particular individual when counseling them or when designing services for them. So I understand that there are many differences in the clientele that we serve. In an hour, I have to try and cover sort of the foundations for some of these topics. Excuse me. That seems to be a blank slide. All right, there we go. Our goals for treating substance use and co-occurring disorder. Properly assess the client using a multidimensional tool. And by that, I mean using a tool that's comprehensive and looking at the whole person, looking at really all aspects of their life and determining which areas require attention, at least in your mind or in the client's mind, usually a combination of both. ASAM is an example. The American Society of Addiction Medicine is an example of a multidimensional tool that looks at different dimensions of health. To provide integrated and coordinated longitudinal care using evidence-based approaches. As you're probably all aware, addiction has been recognized as a chronic disease, a chronic, often relapsing disease, but most diseases are that way. So really what we're looking at here is how do you coordinate and integrate other kinds of healthcare, other kinds of social services into addiction treatment, or vice versa. Longitudinal, of course, speaks to the fact that addiction treatment is oftentimes a long-term health issue, and it requires different dosages of care at different points in a client's treatment. So people should be able to move around within the system of care fluidly without being, as we have done in the past, sort of compartmentalized into, okay, you're going to go to a residential facility for X amount of time, then we're going to step you down to this level of care, etc. And it's been very rigid. And speaking in general terms, the addiction treatment field has been very rigid in how we place clients in a particular level of care. I think we have to look more broadly at, first of all, what is the client willing to participate in? What is their need in terms of the assessor? And then how do we match what the client wants, what the community resources offer, and what you think is important as a clinician? Combine all of those things and try and find an appropriate level of care that meets the need. It's not an easy thing to do, I know that, but when we're talking about healthcare issues, they're not easy things to deal with, and they're very complicated. I think people with addiction disorders have typically been underserved in the sense that they haven't received much of the care that they should have received from primary care, from mental health counselors, and other kinds of professionals in combination with the addiction treatment. So I'm a big fan, I'm a big supporter of integrated care, as long as it's done in an intelligent way and the assessment process is comprehensive enough that it captures the important characteristics of the individual. The therapeutic alliance in providing an opportunity for the behavior change is important. I'm going to use an example from a previous position I held, which was the director of a large withdrawal management program or detox center in St. Paul, Minnesota. It was a 50-bed facility, and one of the things that we did there was that we looked at, first of all, how the service was provided, and it tended to look more like a detention center than a healthcare facility. So what we did, in part anyway, to change that was to change our approach to client care, to build really on that therapeutic alliance with clients, to ask them what was important to them, to ask them if providing groups for them was helpful, if environmental changes were important to them, other kinds of things that we could change in the environment and change in the way that we approached clients. Through doing that, and that's a very simplified version of what we did, but through making some of those changes, the therapeutic alliance was strengthened between our staff and the clients we served. There was much less tension, there was much less violence. The clients understood that we were there to help them, or at least listen to them. And the staff understood that by doing that, it reduced many of the tensions that existed previously with the former philosophy of care. Behavior change occurs when people believe that they can do a thing. So providing hope, providing someone to be empathetic and listen was one way to do that. And this is more the result of what happens as a result of doing those things. But the goal should always be to improve the client's overall health and wellness. It doesn't always mean that they'll remain abstinent from alcohol or other drugs, but it does mean that their lives are measurably better as a result of interventions. Now, to measure outcomes. We can do the best work in the world, and if we don't collect outcomes and measure them in a way that's understandable to funders and to the people that make decisions around program development, if we don't measure those outcomes and have a well thought out method of monitoring client care, then all of our best efforts can be unrecognized. So we need to really pay attention to not just measuring outcomes, but to pay attention to which outcomes we're measuring and why that's important. I think for too long we've looked simply at abstinence as a measure. And while that is one way to look at this, there should be broader measures put in place that say, has this person improved in other areas of their life, even though they're not completely abstinent? And whatever those measures are should be a part of an evaluation plan that the agency has or comes up with to determine if overall health and wellness is being addressed with the clients and if it's being effective. Evaluation can be a useful tool even if it shows that what you're doing isn't effective. Obviously, that means that you can look at what you're doing and say, well, we thought this was working, but apparently it's not. Let's adjust and try something different. And to provide informed consent to a client, clients should be made aware of all available interventions that they can take advantage of, all available resources that they can take advantage of, even if your particular agency doesn't offer those things. So if a client presents to your agency with a particular need or a particular desire for care that you can't offer them, it's important that we let them know about other places in the community where they could get that support. Again, the idea here is just to not be limited in the scope of helping the client by only offering them what your agency has at its disposal. So what does all this mean? We have a responsibility to improve service delivery and monitor client outcomes. As addiction professionals, it's our responsibility to look at how we do business and find ways to improve it. Every business, every successful business does that very thing. I don't think we want to ever get comfortable with how we treat clients. I think in the sense that I don't think we want to say, well, we're doing what we need to be doing and there's no need to change. I think we have to keep our minds open to all of the evolving science and research that's being done and adjust our treatment approaches accordingly. I think the word treatment has, in addiction treatment anyway, has a connotation that treatment means a 28-day stay somewhere. Not in every case, but that's what generally I think what the public, the public perception of what addiction treatment is along those lines. And I think the term treatment, as we move into a new era of healthcare with integrated healthcare and coordinated healthcare, I think we're going to see the word treatment reflect treating the whole person's needs and not just their addiction. So again, the word treatment might mean treating someone's ability to maybe social skills or what do I want to say here? Treating aspects of the person's life that would enable them to improve their situation or improve their health. Broader understanding of it. As professionals, obviously, we have a responsibility to stay informed about evidence-based practices, best practices, and promising practices. There's a good website. It's called NREP, National Registry of Evidence-Based Programs and Practices. On the NREP website, there's a list of evidence-based practices. These have been vetted and researched approaches. It gives you a sense of what particular approaches are being supported by science and research. And you can obviously look into further than explore those particular approaches. But we have a responsibility as professionals to keep abreast of what's going on in the field and what some of the cutting edge approaches are that are being implemented. And those in leadership positions, if some of you are clinical supervisors, managers, directors, leadership in this field especially is aging. So as an aging leader myself, I'm constantly thinking about succession planning and how do we build the next generation of leaders in this field and prepare them for the changes that are coming and for the changes that we haven't anticipated yet. But to build those leaders amongst our workforce now so that they're ready to step into our shoes when people like myself are looking to retire at age 93. Therapeutic relationship. I'm going to reference the detox center again, just because it's a good example of a place where these kinds of things are obvious. The therapeutic alliance in developing rapport, finding common and shared goals, and building trust and safety with clients is, in my mind, probably the most important thing we can do if we're going to engage people in the helping process. This begins not just with the clinician, but it begins with the receptionist, with the technician, with the person on the other end of the phone that takes the client's call when they initially petition for care. It's whoever comes in contact with the client. This isn't a clinician responsibility alone to establish rapport, to try and establish rapport. This involves everyone in the organization. A client is going to be rather hesitant, rather anxious about seeking treatment. They're going to be uncertain as to whether or not it's going to be effective. Are people going to be nice to me? What's the environment like? All of those questions. So if an organization can approach those opportunities when clients are first seeking out care and engage them in a way that's therapeutic, that establishes rapport, that gives them a sense of safety and trust, they're more likely then to follow through with whatever recommendations might be provided to them. So it's not just a clinician's responsibility to do these things, it's the entire organization's responsibility. And of course, we have ethical responsibilities to treat the client in an ethical manner. If this isn't a webinar on ethics, but if you have questions about an ethical approach, a particular ethical approach to take with a client, always consult a clinical supervisor, a director, or a colleague, whoever might be available. Ethics can get a bit murky, and it's not always obvious what the right path is. Be aware of the power distribution. As a clinician, you will always have a status of power over the client, whether you come across as trying to present yourself as being on an equal playing field. It doesn't really matter. Just by having your position and your title, it's going to set up a situation where there's a power differential between you and the client. And you have to be mindful of that, because oftentimes I think clinicians don't recognize the influence that they have over clients simply by their title and their position. So you have to be kind of careful how you approach people that are very susceptible oftentimes to suggestion, or susceptible to doing something simply because you mentioned it as a thing that you feel is important. Part of my screen is cut off here, so forgive me if I miss a word. But positive reinforcement, encouragement, instill hope, build self-efficacy. All of these things are a part of the therapeutic relationship. I think genuine empathy is something worth mentioning here, worth highlighting here. People recognize when you're being genuine. And even if you don't know the answer to their question, or you say that you can't help them with a particular problem, they recognize that you're interested and that you care. And that's really the key. It's not that you have to have all the answers to what the client might need, but it's the fact that you genuinely appear to care about their concerns, whatever they might be, and that you're listening to them and expressing empathy in a genuine fashion. That's really important, and it's not something you can fake, I don't think, effectively. If you don't feel empathy for a client, but you recognize that's the clinical path to take, I think then you have to at least do go through the process of reflecting, using reflection and other kinds of empathy skills. Finding attainable and realistic goals for a client is important as well. You want to instill hope. You want to instill the belief that they have self-efficacy and that they can achieve some of these things that they would like to achieve. But you also have to maintain a realism about which goals are attainable, at least in the current situation that the client finds themselves in. I think can set them up to really be disheartened if we set goals that are too high or unrealistic and the client can't achieve them. It feels like they're not making progress. And then model adaptive interpersonal functioning. Again, just through your role as a clinician, clients will pay attention to how you interact with others, how you respond to situations. Body language, tone of voice, everything is important. So when you're with a client, I think it's a good idea to just keep that in mind so that when you, say, are interrupted by somebody during a session, your response to them can be a good example of how interpersonal relationships can be managed. Any situation that could be, I think, a learning opportunity for people that have maybe never had good role models or people in their lives that could provide them with examples of good interpersonal kinds of skills. You have that ability to do this with clients, even just during your session or wherever they might be observing you. I think some of these things are probably fairly obvious, but positive change as a possibility. I've worked in a variety of facilities, different states, in rural and urban settings, and it doesn't matter. But if people believe change is possible, and they're oftentimes just asking us if we believe change is possible, I think without that belief, without that hope, it's likely that we're not going to see much progress in terms of behavior change. I think we really have to emphasize strengths. We really have to emphasize the positive qualities that someone already possesses, even in the most dire circumstances, and highlight those and build upon those. People already know usually what their problems are. They already know or hyper aware of what some of their shortcomings might be. So we don't need to really focus, I don't think, on the problems that exist. It's a slide. This is a slide again from the ASAM. I'm going to see if I can make my slide bigger here. Yeah, that's better. Okay. You're not familiar with it. It's one of the few tools that's recognized nationally as a multidimensional assessment tool and a guide for how to appropriately place people in levels of care given their severity in different dimensions of their health. ASAM's clinically driven, not program driven. There's no prescribed length of stay. It's meant to be flexible and fluid. There's an interdisciplinary approach to care involving other professionals, primary care, docs, nurses, mental health professionals, peer support, other kinds of healthcare professionals should be included in this sort of interdisciplinary, multidimensional approach. Include informed consent. It is outcomes driven and clarify medical necessity. That last piece is important. Addiction has a very pronounced medical, there's a medical need attached to treating addiction. And it's not just because it's a brain disorder, but it's because there are many complications that, as you know, go along with addiction. Complications with health, physical health, complications with mental health, etc. And focusing on those additional kinds of health needs is important. And I firmly believe that to be more effective addiction treatment needs to work more closely with the primary care world. And these are just the dimensions of ASAM in case you're not familiar with them. Just going to look real quick and see if there's anything I wanted to point out. These dimensions are rated usually on a mild, moderate, or severe rating. And the dimensions are interactive. In other words, one dimension rating might affect another dimension's rating. So it gets a little complicated. I know several organizations I've worked with or have been familiar with have tried to make this a sort of one-page simple assessment tool. And I think that can be helpful, but you don't want to oversimplify it either. So if your organization doesn't use ASAM or does but uses it in a very basic way, I would encourage anyway a more in-depth look at it and see how these ratings impact treatment plans and how they should impact treatment plans and how they can impact the referral to the next level of care or the next service that a person might need. I'm going to talk about theory. It's hard for me to know what's on the current exam for licensing. So traditionally, some of these older theories have been a staple on the exam, and they probably should still be reviewed. So as we go through theory, I recognize that some of these theories are rather old. Aspects of them, continue to be used, but I'm not sure that some of these theories will survive. I shouldn't say that. I'm not sure some of these theories will be prominent in the coming years as newer and more sort of combined theories develop. But I want to talk about them because if you're taking the exam at some point in the future, you're going to probably need to know about them. We won't go into a lot of depth, but I want to touch on them. Behavioral theory by Skinner, cognitive behavioral therapy is one of the most often used. Contingency management or incentivizing, providing a reward for a particular kind of behavior. Sometimes that's used in drug screening. It can be actually a fairly effective way to, in working with people, to say, if you can provide, 3 negative UAs, let's look at reducing your bill, or you get a coupon for $15 in gas or something of that nature. But the idea then is to incentivize people to change their behavior. SBIRT is, I think, a very effective tool, screening brief intervention and referral to treatment. It's reimbursable, I believe, through Medicaid. The problem right now that we're running into, at least in Minnesota, is that physicians or primary care workers often don't feel like they have the time to add another screening tool to their already sort of compacted client encounters. So it's asking physicians or asking nurses, other healthcare professionals, to add this to what they already do, and they're saying, enough's enough. We have 10,000 screenings we have to ask of somebody when they come into our office for 15 minutes. But if we can find a way that this sort of tool could be used in healthcare settings on a regular basis, I think it is an effective, and it's been shown to be an effective way to intervene at an early stage to get people referred into a more in-depth treatment program. So SBIRT can be effective. Part of the difficulty in implementing it has to do with timeframes associated with healthcare professionals. Rational emotive behavior theory by Ellis. Motivational interviewing is commonly used now. I think I would caution clinicians, if they haven't had a formal motivational interviewing training, that they go through that. because I think, in my experience anyway, I've come across clinicians who say that, yes, I use motivational interviewing, and then I supervise them or I observe them, and it becomes apparent that maybe they don't. There's more to motivational interviewing than just being client-centered. There's obviously a well thought out theory here that requires specific skills and strategies in order to make it effective. So if you haven't had a motivational interviewing training, a formal 2 or 3 day training with follow-up, I would recommend it. Stages of the theoretical model by Declaration was developed, I believe, for smoking cessation and then adapted to alcohol use. The stages of change is also used, and it's used in combination with motivational interviewing. We'll, I think in one of the slides here coming up, we'll list the stages of change. Many treatment programs are finding that they're being inundated more and more with people who are in the early stages of change, pre-contemplation and contemplation, and finding it difficult to engage those folks in the treatment process. Again, that's where motivational interviewing can be used in combination with stages of change work to make that more effective. And then medication-assisted therapy. It's been about a year and a half since I've done this webinar, and that terminology may have changed a little bit, but it refers to medications used oftentimes to treat addiction. Things like buprenorphine, methadone, naltrexone, Vivitrol, which is an injectable form of naltrexone. There's others, I'm not thinking of them right now, but that's what medication-assisted therapy is meant to mean here. Just a little insight there. So touch on behavior theory real quick, and these are some of the primary constructs under behavior theory. I'll do this for the other theories that we mentioned in the previous slide. And essentially, behavior theory says that behavior is learned, therefore it can be unlearned. New behaviors can replace old ones, focus on the observable, how people act, react. And behavior theory is less interested in cognitive emotional states and believes that theory represents learned habits. Conditioning, it's the association between a stimulus and an involuntary or automatic behavior or response. So craving can be a conditioned response triggered by stimuli that the client may or may not be conscious of. There's an interesting study that was done in the Netherlands, and I don't know the name of the study, but I think it points something out about craving that is really kind of interesting. The study used subjects, willing voluntary subjects, who were actively experiencing addiction, who were sober at the time but had addiction issues at least recently in their lives. And they had these folks sit in front of computer screens, and these computer screens to the individual looked like they were blank, like they were turned off, when actually the researchers were flashing images across the computer screen at 1/1000th of a second. So the images were going by so quickly that the screen just looked blank. What the researchers did was they placed images of neutral images like houses and puppies and things like that in this progression, or this fast progression of slides, and then they would mix in slides that included pictures of alcohol, included pictures of needles or cocaine or something of that nature, and they monitored the brains of these individuals that were looking at the computer screens, and they found that the person's brain reacted, that is, the reward center of that person's brain reacted to the images of cocaine or alcohol or whatever drug might have been flashed across the screen. Even though their eyes couldn't recognize the stimuli, they didn't see it through their eyes, but their brains recognized it, and it triggered craving. So to me, that supports the notion that craving can be play an important role a very subtle role in client recurring use. If someone sees something that stimulates craving and doesn't even recognize that they saw it, it can be a very powerful mechanism for driving that person to taking their first drink or using a drug. Now that sounds a little scary, but the point is I think it takes some of the mystery out of why that happens. Probably in your experience as well, you've come across clients that say, I don't know why I drank again, or I don't know why I used cocaine. It wasn't even on my mind. And this helps to explain a little bit behind the brain science of addiction and say there may be reasons why you did this. And it's not that you can prepare for it so much as you can at least recognize when these things might be happening and come up with a strategy for how you're going to deal with that when it does. But people feel like they're crazy, like they don't know what triggered them to do a thing. And some of that's not being crazy, it's being subjected to craving that results from seeing things, your brain seeing things that your eyes don't catch. Operant conditioning refers to the association between a voluntary behavior and a consequence. The belief is the nature of the consequence will impact whether the behavior occurs again. I won't editorialize on that, that's just the theory. Motivational incentives, as I talked about, are meant to reward positive behavior. It's just an example here of a particular approach. CBT, or cognitive behavioral therapy, is probably what most of us are aware of and have used in the past. And behavior therapy helps to weaken the connections between troublesome situations, your reaction to them. And cognitive therapy teaches you how certain thinking patterns or feelings impact behavior. Very, very simple summary is that CBT attempts to help patients recognize, avoid, and cope with stressful or unhealthy situations. Relapse prevention is often an area where you see CBT applied. Rational emotive behavioral theory, REBT, in a nutshell. This is an example of how the theory works. Something happens to the client has an irrational belief about the situation, the client has an emotional reaction to the belief, and the therapist helps the client recognize errors in thinking that led to the irrational belief and find alternative ways of thinking about the event. So the example I used was, I was only arrested for drunk driving because that cop has it out for me. We've all heard that one before, I think. So it's helping the client recognize that that's an irrational belief and that their reaction to it is an emotional response, and then finding the errors in their thinking. Stages of change model that I mentioned. These are the 5 stages of change: pre-contemplation, contemplation, preparation, action, maintenance, relapse, and recycle. Or some people, some researchers in the field, that last bullet point, relapse and recycle, would label it termination, meaning the problem had resolved and the person no longer required ongoing therapy or ongoing care. Termination might not be the best word to use, but the example used in that case would be somebody who quit smoking and 20 years later it's not an issue for them. I think most people in addiction treatment would argue that even if that appears to be the case, that maintenance or ongoing support of some kind is necessary to avoid relapse or continued use. I'm going to back up here. Just to clarify, pre-contemplation, an example of that would be somebody who doesn't recognize that they have a problem. They don't see what they're doing as problematic. Contemplation would be when somebody starts to think about their problem a little bit or think about the fact that maybe they have a problem. Preparation would be a point at which the client believes, okay, maybe I do have a problem, but what am I going to do about it? Maybe they'll call a couple of treatment centers to see what their programs are like, do some exploration around what options are available. Action would be when somebody actually follows through with say, going to a treatment program or going to a counselor, taking some sort of action to resolve the problem. And then maintenance would be, of course, to maintain the changes that were made during the action stage. If somebody relapses in any point in this in these stages of change, sometimes that person will revert back to an earlier stage of change. Sometimes it's a matter of just relatively quickly bringing them back up to a level they were at before the relapse occurred. It's kind of a long slide, gives you a little bit of an overview about motivational interviewing. And I don't need to read it all to you. The belief behind motivational interviewing that supports its efficacy is that by engaging people in a way that minimizes the power differential between the counselor and the client, forms a therapeutic alliance with the client so that decisions are made based on mutual kinds of goals, ways in which I think motivational interviewing developed out of client-centered approaches. Who's the guy? I'm not thinking of the therapist who had conditional regard for clients. Sorry, I can't think of the name of the theory. But motivational interviewing is intended, yes, to listen to the client, to empathize with the client, to bond with the client in a therapeutic way, but also to guide the client in a direction that's beneficial for them. So there is a component to motivational interviewing that works to direct people in a particular direction. I'll think of that other theory. I'll say it. Collaboration, suggestion, self-rule, empathy, accurate empathy. Developing discrepancies means that you kind of help the client to understand what their actual situation is versus how they see their situation. Develop sort of gently develop that discrepancy with the client so they begin to recognize their situation is not quite possibly isn't quite what they think it is at the moment. It brings a little bit of self-exploration into the picture for the client. Rolling with resistance is a key, I think, to any sort of therapy. If somebody presents with a lot of resistance, a lot of negative kinds of comments about their situation, about your treatment program, whatever the case may be, not challenging people on their statements is a good way, as far as I'm concerned. If you cannot, you don't have to validate their opinion, but simply let them know they've been heard. Let them know that their concerns, outlandish they might be, have been heard, and that you recognize that they're upset for whatever reason, or that they are resistant for whatever reason. Oftentimes that's enough to get past that moment. People don't necessarily want you to convince them of another position, and they don't necessarily want to just badger you, but oftentimes it's a way for people to express themselves. Resistance comes out in a way of people expressing themselves, that they're frustrated, that they have an emotional buildup in them that they're not easily able to express. And the anger comes out sometimes of whoever happens to be in front of the person. I've seen some of the most challenging clients de-escalated simply by listening, empathizing, and reflecting back to them what they were saying. I don't think I can emphasize that enough in terms of really getting past those moments where somebody is not willing to engage in the treatment process. You can often get past that early resistance and move right into a helpful discussion with the person if you can just be patient enough and emotionally detached enough at the moment to just reflect back to them what they're saying. People have to believe in self-efficacy. They have to believe that they can do a thing. Supporting that is an important part of motivational interviewing. And this I already said earlier. A lot of people, or some people anyway, think they already do motivational interviewing, but when we look into it a little closer, maybe not quite.
Bob, I thought this might be a good time to stop and take some questions, if that's okay with you.
Sure.
So if you have, a couple people have been writing questions and comments, and so thanks for that. And somebody mentioned that the person you were trying to think of, their name was Rogers. Is it Carl Rogers?
Carl Rogers, yes. Thank you. Thank you.
Yeah, thanks to those who reminded us of that. And the Q&A pod is just to the right of your where the presentation is, and the field to write in is at the very bottom. So please submit questions if you have them, and we'll just take another minute and see if we have any questions come in at this point. But feel free to keep sending them in throughout, and we'll take breaks as we need to and get to those.
Thanks, Kate.
No problem.
It's a screening tool used to assess clients' risk of having an SUD or a substance use disorder. It's a screening tool, not estimate. So it looks for identifiers that might indicate somebody has issues that require further intervention. Brief intervention is very brief. It's 3 to 5 minutes, usually a motivational discussion with the client concerning the screening results. Referral to a specific resource for additional assessment and or treatment service. If SBIRT is being implemented, it's a good idea to have referral sources, 1 or 2 specific ones, or a handful of specific referral sources that you can rely on, so that if somebody says, yes, these screening results concern me, what you've talked about has led me to want to explore treatment further, then you have a number right there that you can call and set them up at the moment. If there's a gap between the screening and assessment or the brief intervention and getting them referred to treatment, there's a good likelihood they'll drop out of the picture. So there needs to be a referral process that's linked very closely to the brief intervention. And then a warm handoff to the treatment provider, whether that's a joint phone call with the screener, the client, and the treatment provider, but some way to introduce the client to the treatment provider personally, so that they have that connection. And that anxiety around calling a treatment provider or seeking treatment on your own can prevent a lot of people from doing that. So if the screener can help with that process, people are more likely to follow through with the treatment end of things. I mention these theories because they're public health theories, but they show a lot of promise in terms of treating whole person, providing whole person care in that light. So quickly, I just listed them here. I doubt that they'll be on any sort of licensing exam, but if you're interested in looking these up, it might be helpful to you as a professional. The social ecological model is one that is often used. You may have heard of the ROSC model, Recovery Oriented Systems of Care. It's based on an ecological model. The ecological model looks at all those influences in a person's environment, social and environmental influences that impact their behavior, that impact their health. So it's taking into account not just the person, but the context in which the person lives when determining treatment interventions or other kinds of interventions. So the ecological model is worth looking at if you're not familiar with it. These other models I found were, if you look them up and read in more detail, I think you would find that they fit oftentimes with the population that we serve. Co-occurring disorders are a common element of the population that we serve. I've seen statistics of about 80% of people who enter addiction treatment have some sort of co-occurring mental health disorder. So the two fields overlap. There's not, and there shouldn't be, a distinction between mental health and substance use on the surface, because oftentimes the two are so intertwined that there's no point in trying to separate them out and treating them separately. Integrated treatment seeks to treat the whole person, as I've said 100 times, mental health issues, addiction issues, and physical health issues. If these things are treated concurrently by a multidisciplinary staff and at the comprehensive done, the effectiveness and the outcomes will improve. So the challenge right now in the healthcare field, especially the behavioral health field, is how do we do that? How do we combine our efforts, combine our service delivery with mental health and primary care providers? And it might seem like that's not a big problem, but historically, addiction treatment has evolved pretty much separately from these other kinds of healthcare. As a result of that, we don't always talk the same language, and we don't always refer to some of the issues in the same way. So there's a communication problem often between different kinds of healthcare and addiction treatment. There's also a lot of stigma that persists around substance use that prevents, I think, community acceptance of integrated care to some extent. In recent years, I've noticed that primary care professionals and mental health professionals have become very interested in partnering with substance use disorder programs. And again, the challenge is it has to do with things like funding and the different funding streams that are out there for all of these different professions, and trying to find a common way to pay for substance use disorder treatment, primary care, and mental health without having these different systems of not just care, but different systems of funding. So there are challenges ahead of us, but this is the direction everybody's headed in at the moment. It's just kind of a race to see how we get there. The Affordable Care Act really paved the way for this. The idea here is not just to provide integrated care, but is to treat a person before they get to a stage in their illness where they require emergency care or residential care. Again, historically, in healthcare, we've treated people at the back end of their disease when the disease has already progressed and when the cost for care is extensive, like in emergency rooms, detox centers, residential treatment. So if we can provide more comprehensive integrated care earlier in the disease process, we stand a better chance of preventing these acute care situations that cost more and are less effective. Gambling's been included in addiction disorders under the DSM-5, so it is now considered an addiction disorder. Problem gambling, certainly an issue here in Minnesota, and I'm sure other states. And really we're at the early stages, at least in my state, of integrating problem gambling into the picture, but it is on the radar. It's a brief description of what a co-occurring disorder is. So obviously it's a combination of a substance use disorder and a primary mental health disorder. PTSD, I believe, is in its own category now in the DSM-5. Somebody can correct me on that if you know that not to be true, but I believe PTSD is no longer considered an anxiety disorder, but has its own classification in the DSM-5. And some of the characteristics of folks who have co-occurring disorder, I think some of this is due to our systems problems I talked about earlier, where we have sort of separate systems of care for mental health, addiction, and primary care. The more that's integrated, I think the more likely the treatment outcomes will improve. These are the axes. I don't think they're going to ask these questions on an exam, primarily because the DSM-5 doesn't have axes anymore as a part of diagnosing. Substance use disorders are now on a spectrum of severity, so they're measured similar to the ASAM in terms of severity by using mild, moderate, and severe. So just as an example now, alcohol, what used to be alcohol dependence, I forget the code, but alcohol dependence is now diagnosed as alcohol use disorder, mild, moderate, or severe with the code. I mention these just in case you can get copies of these slides, just in case you want to look up the axes. ASAM's a good tool. I'm not a salesman for ASAM. It's the one tool that I can think of that's universally used as a multi-dimensional assessment tool. Other than the DSM-5, ASAM is about the only other nationally recognized tool for assessing and placing folks in particular levels of care. So that's why I mention it all the time here. Slides might be out of order, but more characteristics of co-occurring disorders. Medication management is an important aspect of treatment for folks with co-occurring disorders. Plays a role also in treatment retention and completion. There's a lot of debate around medication-assisted treatment, primarily with methadone, as to whether that should be an option for treating opioid dependence. I won't take a stance on that one way or the other, but I do have to point out that the research is pretty clear that people who are on methadone maintenance regimens or programs do have much better outcomes. So it's one of those times when, again, we have to maybe let go of some of our beliefs and look at the research and the findings and say, okay, maybe there's something here we need to look at. Suicidal behavior is obviously more prevalent in this population. Difficulties in functioning, shorter time in remission of symptoms. It's a very complicated population, and these are the folks that we're seeing in treatment now. Probably always have been, but these are the folks that we're seeing in treatment now that we need to adjust our approach to better accommodate. One thing that I think I still see too much of is that there's an emphasis placed on people entering treatment on being punctual and being able to organize their lives. There's good research that shows that in the example of alcohol use, for somebody that has a severe alcohol use disorder, it can take up to several months before their brain returns to a normal level of functioning. And what I mean is, for that 3 to 4 months after abstinence is achieved, there's still an impaired functioning in the frontal lobe, the part of your brain that's responsible for executive functioning. that part of the brain is still impaired. So people have difficulty planning ahead. They have difficulty managing their lives and thinking logically and rationally. That usually improves with time, but for that first few weeks, few months of abstinence, understanding that that person's ability to think logically is impaired and reason well. At the same time, the reward center of the brain is still very active. So it's very, that reward center of the brain is still very active in the sense that the person responds to craving, sometimes very, very strong craving. So you have a situation where the person's brain experiences intense craving, and at the same time, that person has a reduced ability to make good decisions. Well, the way we've treated people typically, in real general terms, in the past is that when somebody gets sober for a month or 2 months, and they don't follow through with particular kinds of recommendations, or they don't show up for appointments, it's often not that the person doesn't have good intentions, but oftentimes during that period, they simply don't have the ability to follow through with things as well as we would expect them to. They may walk, talk, and act normally, but their brains have simply not readjusted and healed enough to function properly. It's something to keep in mind, and I really cringe when I see programs that say, well, if you no-show for an appointment, you can't come back, or you get bumped to the end of the line, or whatever the policy might be. It's really kind of punishing people for exhibiting a behavior that's the result of the disease. The same thing goes for treatment programs. If they say, if you don't do these things while you're in treatment, you're going to be discharged. Well, oftentimes those behaviors are the very reason that they're in treatment, and that we can use those moments, when people show poor judgment, or they show that they can't reason well. Use those moments to help educate them, help them through those moments, and recognize that this is a part of addiction, and it's a part of addiction that can get better with time. A few points about adolescent co-occurring disorders. So the median onset mental health disorder at age 11. Many places use this primary locus of care by severity chart to sort of determine where the problem lies, from the low severity to the high severity in both directions, the X and Y. What is that? The X and Y axes. The intention here is to sort of localize where the primary kinds of problems are, where the other problems exist, and where they fit in a hierarchy of need. This is the medication-assisted therapy or pharmacotherapy. I think this is the last part of the webinar here. I want a little time for questions. When I worked at the detoxification center, we used medication for alcohol withdrawal, certainly, and we were looking into drugs like naltrexone and Vivitrol and Camprol for craving for alcohol, and sometimes opioids. Methadone, in a lot of places aren't methadone dispensers, but many treatment programs anyway can accept methadone from a methadone provider and dispense the medication once it's delivered. Methadone, buprenorphine, Suboxone, common drugs that are used for opioid dependence. I suspect that drugs for alcohol craving and other kinds of drug craving will be making the market soon. Right now, as far as I can tell, they're in limited use. Vivitrol is an injectable form of naltrexone and lasts for about up to 30 days. So naltrexone is a daily dose that a person would take to help with craving. and also reduce the effect of the alcohol if they did drink. It's oftentimes confused with what is it? Geez, sorry, my brain is not functioning well. What's the drug we use for deterrent? Jeez, I apologize for that. But it's confused with drugs that make you sick. Somebody, whoever helped me with the last question can add that to their comment. Anabuse, sorry. Acamprosate. Okay. Some of the disulfiram is anabuse, and that's really I don't think the research backs that up as an effective way to deal with alcohol use. I think it's a deterrent for up to a period of time, but for long-term change, again, somebody can correct me on that, but for long-term change, I'm not sure that anabuse is really an effective means of inhibiting or enhancing, I should say, long-term abstinence. Opiate's a term that refers to medications derived from the opium poppy, heroin, morphine, codeine. Opioid is a more general term that includes opiates as well as synthetic drugs that we all hear about. That's a big problem right now, and it's getting a lot of attention, at least in Minnesota, but I think nationally. Overdoses on opioids is becoming a major problem, and I believe opioid or overdose deaths have surpassed motor vehicle accident deaths as a leading cause of death, accidental death. Just another kind of interesting point here is on average, alcohol-related deaths result in an average of 30 years of potential life lost for each individual. So on average, alcohol-related deaths reduce a person's life by approximately 30 years. Basic opioid facts. I'm not going to spend a lot of time on this, but let me just read it real quick. Fentanyl patches, I know that was something that people were, I've had people in a detox center chewing on them. People will want to get high, and when they become uncomfortable enough from opioid withdrawal, they will look for any way to feel better. It's not life-threatening. Alcohol withdrawal can be, but not opioid withdrawal. It's very serious, however. I'm not downplaying it. I'm not going to read all of this to you, but you can look at the slides, maybe download a copy of them. And just a brief history of opioid treatment. Methadone was approved way back in 1964, so it's as old as I am. Naltrexone was approved in 1984, and I don't think it really went into widespread use until after it was what you see here, after 1994. It was approved for addiction, alcohol addiction. Just more history. Buprenorphine and Suboxone are relatively new to this area. And I've heard good things from doctors about buprenorphine and Suboxone, but I know, as I've said, there's a lot of controversy around using these drugs. I'm going to move along because I'm running out of time here. I'm relying on the ATTC for these facts. Addiction is pathological use of substance use and may or may not include physical dependence. That I'll attest to. Although I want to refer back to the DSM-5 and the fact that substance use disorders are now on a spectrum. So words like dependence and abuse have been done away with. You know, I know the prevailing thought is that therapy in combination with medication-assisted treatment is more beneficial, but I have to say that some of the research doesn't show that. So I don't know if that's a result of the type of research it was or what was going on, but I haven't seen clear evidence yet that therapy in combination with medication-assisted treatment is more effective. And I only say that because I like to try and say things that have some data to support them. And again, if someone out there has a good article, a good research article that shows that this is true, I'd welcome that. A lot of people believe that using buprenorphine provides people with a rush similar to heroin. That's not the case. Again, this comes back to educating people in the community, not just health professionals, but others, about what's true and what's not with respect to addiction. Naloxone is a drug that helps to prevent overdose death, and that's becoming more readily available through law enforcement, through first responders, and ERs. So I believe they have a nasal form of that, so it can be easily administered. But I know in Minnesota, anyway, that's becoming a more common drug to prevent overdose death. I won't go into nicotine dependence much. I think you probably all know quite a lot about that. I hope in the short time I was able to give you a little bit of an overview of best practices and evidence-based practices. The importance of the therapeutic alliance, which to me is one of the key factors in whether or not somebody does well in treatment or engages in treatment in the first place. Co-occurring disorders as requiring a need for integrated, multidimensional, multidisciplinary care. Pharmacological treatments that we currently have were briefly discussed at the end there, but I think you'll see an advancement in the kinds of medications that are going to be on the market. I'm just predicting this for craving and for other kinds of addiction treatment. But I'll end with that, so we have a few minutes here if anybody has any questions or comments they'd like to make.
Thank you so much, Bob. That was a great overview. I hope everyone benefited from that quick overview. And I just wanted to that we just had a slide on nicotine addiction, and there were some comments and some discussion going on about excessive tobacco use and that kind of thing, especially with co-occurring disorder. That was, if you didn't happen to notice the conversation going on in the iPod, check that out. We do have a question from Estelle. She asks, there have been times when a client tested positive and denies. How do you use motivational interviewing to handle that?
Can you repeat that for me, Kate?
Yes. Estelle is asking, when a client tests positive but denies, how do you use motivational interviewing to handle that?
That's a good question. You know, I used to manage a drug testing component to a treatment program. And what we found was, and what I believe is, that that we shouldn't be in the role of trying to be police for catching people who use drugs or, during their treatment phase. The idea should be really, and the message should be to the client, that we're trying to understand what's going on with you, and it helps us to do that if we can get an accurate picture of whether or not you're using a particular drug. So I really think if it's turned into a therapeutic kind of intervention where we say, okay, your UA was positive, and I know you're saying that you didn't use anything. Let's try and explore how that could happen. How could that be? And my only reason for wanting to know is so that I can provide you with the kinds of care that will help you in whatever way I can. So I think the message needs to be steer away from being punitive in any way. Unless, of course, you have to. You might say, I have to report this to your probation officer, but let's think about why this happened, and let's think about ways in which we can address the issue. If you absolutely didn't use, then let's find out how this could have happened. I know that can go back and forth, but again, I think the point is, the fundamental point is not to use drug screens or drug tests as a means to catch people being bad, but rather an opportunity to engage in a therapeutic discussion about why the test was positive and why they're feeling the way they are about it.
Great, thank you, Bob. We had another question from Alexis. She asks, why are counselors so committed to the confrontational style in chemical dependency treatment?
Because that's what we've been brought up to understand is effective. That's how the field evolved. And the belief there was that people had to face up to the realities of their situation. And if they didn't face up, then by God, we needed to tell them what was really the case and drill it into them until they agreed with us. What's changed that to a large extent? Science behind addiction and understanding how addiction affects people's brains. That and that we've applied research to outcomes, and we've determined that people often avoid treatment or don't stay in treatment because of these confrontational approaches. And also, the reasons they're doing the things they are rooted oftentimes in brain disorders, whether it's a co-occurring disorder, whether it's just due to the addiction itself, impacting their behavior, their thought processes, and certainly their emotions. So the more we understand about addiction, the more broad sort of understanding we have of it and what's effective to treat it, the more that sort of approach is going away. But it needs to go away. I don't know about some of you. I know 20 years ago, it was still a practice where a client would be put in the middle of a room in a chair, and everyone would go around, clients would go around in a circle and tell them all the things that were wrong with them. There was a Seinfeld episode. George Costanza had a family holiday where that's what they did. Anyway, that's kind of where confrontational approaches came from, and also the reason why they're hopefully going away.
Then we had thank you, Bob. We had another question about referrals for quality motivational interviewing training. I'll ask Bob as well, but I first wanted to mention that we at the National American Indian and Alaska Native ATTC have developed a motivational interviewing training that is specific to Native American culture. So we are in the process of trainers for that, and so if that's a specific culture that you are interested in that training, watch for that. We will be putting that out soon. And then I'll pass it over to Bob if you have other suggestions as well.
Well, not really off the top of my head, Kate. I think the ATTC is a good source for those trainings. I don't have a specific recommendation.
Great. And I did. I'm going to pass on the website too for motivationinterviewing.org. That's another organization that they have certified trainers that they train in that area as well. So another somebody else asking if this is available as a recording. Yes, it will. This will be put up on our website and the link to the recording will also be sent to everyone who attended in a follow-up email, so watch for that. And then Anne Marie has a comment, I think just in to what you were just saying, Bob. She said that behavior is very common with the older therapeutic communities style treatment. Thank God today that there have been more research and supportive models of helping. So yeah, thanks everyone for the comments, and it looks like that's all the questions we have. Bob, did you have anything else you wanted to say before we close out?
Just real quick, I just wanted to comment. I just wanted to point out that that's one of the things as a field we'll have to overcome. That difference between the more progressive, forward-thinking kinds of approaches that are coming our way, and the struggle between that and folks that are clinging to maybe an older model of care. I'm not discounting some of the things that we did 20 years ago were very, very good. Don't get me wrong, but there is a need to throw some of that away and say let's move from this point forward with what we know now and let go of some of those old notions of care.
Wonderful. Well, thank you so much, Bob. It's been such a pleasure having you with us today. Bob is going to be offering the training in November as well, so I hope everyone joins for that. So with that, I'll close us out, and just note that you'll be redirected to our GIPRA survey, and if you don't make it there, the link to the survey will also be included in the email we send out. So thanks again for joining us, and thank you again, Bob.
Very welcome. Thanks, everybody.